Hi, everyone, and welcome. My name is Jen Elder. I'm the director of SAMHSA's Homeless and Housing Resource Center, and we are so excited that you're joining us today for a great discussion about supporting older adults who are experiencing homelessness. Next slide. So to kick off our webinar today, have just a quick disclaimer. HHRC is funded by the Substance Abuse and Mental Health Services Administration, but the views and opinions expressed today don't necessarily represent official views and opinions of SAMHSA or the U.S. Department of Health and Human Services. Next slide. We are joined by our American Sign Language interpreters and a live captioner. If you're experiencing any technical difficulties or accessibility issues, please reach out to us either through our email or via the Q&A feature. Myself and our associate Alicia will be behind the scenes helping with those questions. Next slide. A few instructions. We are joined by a large group today, so excited for that. But with that, all participant lines will be muted and the chat feature will be disabled. But that said, we want to hear from you. So please use the Q&A feature to submit your questions to us. We'll try to get to as many as we can. We have a long time set aside today for discussion, so I think that's fantastic. So we'll try to get to as many questions as we can. If you'd like to access the slides, you can go ahead and go to our website, go to the page on this webinar event, scroll down to the bottom, and the slides will be right there. We'll also make sure to get that link for you in the chat. A recording will be available on the website within a week. Sometimes we get it a little bit sooner than that, so stay tuned. We'll also, near the end of the webinar, provide you with a link for an evaluation. Sometimes the website of the evaluation gets a little overwhelmed at the end, so if that doesn't work for you the first time, just give it a few minutes, refresh. We'll also have that link for you on the webinar event page. We appreciate your time, giving your feedback for that. It'll also come with a certificate of participation. You'll be automatically redirected to that at the end of the evaluation. Next slide. So with that, I am so excited about our panelists today. We have so much expertise to share. Also wanted to give a huge thanks to the National Healthcare for the Homeless Council, who's working in partnership with us today to bring together a diverse group of experts and to share their own expertise on this topic. Everybody's biographies are available on our event page to review before or after the webinar, and everyone will have a chance to introduce themselves at the beginning of the discussion. So with all of that housekeeping aside, no further ado, I'm going to pass it over to Caitlin to get us started today. Thanks so much.
Thanks so much, Jen, and so happy to be here today. Welcome, everybody. My name is Caitlin Sinovic. I am a Senior Program Manager with the National Healthcare for the Homeless Council and National Institute for Medical Respite Care. I'm also an occupational therapist by clinical training and have spent many years also working within healthcare for the homeless, medical respite, and permanent supportive housing settings. So I'm thrilled to be here today talking with my colleagues about the needs of older adults experiencing homelessness. As we'll share over the next few minutes here, there's really a growing need to address the specific needs of this population. So we're going to spend just a little bit of time laying the groundwork to understand what the current issues are for older adults experiencing homelessness. We could go into depth a lot more about all of the issues presented, but we want to kind of just lay the groundwork before we enter into the panel discussion. And so we're hopeful that from that panel discussion, you'll hear a lot about different ideas and strategies that you can use and take into your own community. So after today's session, we are hoping that all of you will be able to describe the considerations affecting older adults experiencing homelessness, be able to identify some promising practices, and also identify some strategies that you can use within your own community. So here I'm going to start with an overview of just kind of the issues facing older adults and experiencing homelessness in the United States. So when we're talking about older adults, this can mean a lot of different things. The United Nations has identified older adults as anyone over the age of 60. Within the United States, often older adults are considered to be age 62 or 65, especially when we're talking about services and systems and what people are eligible for. However, and to lay some context around people experiencing homelessness, when we're talking about older adults, we're often thinking about folks who are in their 50s and older. And in part, that is because in people experiencing homelessness, those even in their late 40s as well as their 50s often present with the health and functional needs of their housed peers that are in their 60s and 70s. So they're facing these conditions and needs of older adults almost 20 years ahead of those who are housed. And I'm going to provide sort of an oversimplification of two groups of individuals who are older adults experiencing homelessness. The first group of folks we have are those who have been experiencing chronic homelessness, who have been homeless for a very extended period of time and are now entering those older ages of their 50s and 60s. But we also have another significant group of folks experiencing homelessness, and these are older adults who are experiencing homelessness for the first time. And I'll talk a little bit about why. So I'm going to divide up these issues as we're talking about. Some are going to be more affecting those who are experiencing chronic homelessness versus those who may be seeking services and supports for homelessness for the very first time. And so what we know is that those who are aging, this group and population is growing quite rapidly in the United States. So we've been seeing this increase for some time, and we know that it's projected to continue to increase, both in part because of the baby boomer population, which is a large population of individuals, is entering this stage of life, but there are also some social and cultural issues that are contributing to this as well. So when we're thinking about those who are experiencing homelessness for the first time as an older adult, we know that health is one of the significant contributors to that. Many times for those who are lower income, they have a significant health event, or the primary income earner in their home has a significant health event. And that results in hospitalization, often a change in function, impacts their ability to return to work. When somebody is unable to return to work after an event, such as possibly a stroke, right? When we are unable to return to work, we suddenly have a loss of income. And even if somebody is connected with benefits, we know that Social Security benefits take quite some time for many people to apply for and to obtain. It's still not the same amount of money or same level of income that they might have had when they were working. Because of the cost of housing and because they're no longer making their income, there are folks who then have a loss of housing. For some individuals, this happens quite rapidly in that they lose their income and lose their housing while they are still hospitalized for this particular health event. And this results in this person experiencing homelessness for the first time. This often happens to individuals, especially those without robust social networks or who have social networks that have income to be able to support them and serve as caregivers. But this may also happen to couples who, again, have that loss of income that contributes to then their first time homelessness. For those who have been experiencing chronic homelessness, we know that that has a significant toll on their health. Those who are experiencing homelessness have high rates and higher rates than the general population of chronic conditions such as diabetes or cardiovascular disease. They're more likely to experience cognitive decline and experience this at a younger age. They are also more likely to experience general geriatric conditions such as incontinence, and they also face significant mobility limitations. And as I mentioned at the beginning, all of these are occurring several years before we might expect those for those who are housed. These go along with the prevalence of mental health and substance use within this population. And although this may not affect everyone, the presence of mental health and substance use often precludes people from being able to access the services that they need to address their health conditions. When somebody is experiencing homelessness because of bias, because of stigma, and because of access to healthcare, folks experiencing homelessness are unable to get chronic condition management. They're unable to get into skilled nursing facilities when they need to for their health conditions. We also know that there's less harm reduction practices within these settings and within healthcare environments where they may be seeking services. And there's decreased accessibility, which really affects and emphasizes the mobility limitations that may not otherwise be so impactful for the individual. And then once somebody is experiencing homelessness, whether or not they have been experiencing homelessness for many years or for the very first time, they're not able to access specialty care that they are more likely to need because of their age and health conditions. This includes things like care for vision loss, hearing loss, mobility needs, and incontinence needs, which affects a significant portion of the population of older adults experiencing homelessness. When they're not able to access that care for things like sensory deprivation, so not being able to see or hear as well as they could, that increases their risk for cognitive impairment and dementia, and for that to be onset much earlier. Additionally, when we don't address mobility needs, incontinence, or vision or hearing, folks are at a higher risk for falls. And these falls, if somebody experiences a fall, often results in needing more significant medical needs, such as if somebody experiences a fracture in their hip or is no longer as ambulatory, that then increases greater risk for other health issues. Unfortunately, because we are unable, or when folks are unable to address those issues, that often results in them needing institutionalization or moving into long-term care earlier, or the need to move into long-term care earlier than other individuals. And so instead of being able to live in the community, they're more likely to be living in institutions. And even more substantially, this also contributes to early mortality across this population. So just a snapshot of accessing health services. So this is the percentage of older adults who accessed services at Healthcare for the Homeless Health Center programs over the past 13 years that this data was collected until 2021. And just like we can see in the first chart where older adults experiencing homelessness have increased overall, the percentage of those individuals accessing services at HCH has also increased. So this really reflects the number of those who are older and experiencing homelessness and also needing services. In addition to barriers to address healthcare needs, older adults experiencing homelessness also have different barriers to accessing shelter than those who are younger. One is which is that shelters are able to medically restrict somebody who cannot meet their own activities of daily living. Without other housing options, often this means that those who are unsheltered, who are older experiencing homelessness, who have these needs, are unsheltered and unhoused and living on the streets. Specific issues, especially incontinence, can result in the person from being prevented from entering shelter, or if they are in shelter, can impact their interactions with staff, right? So if somebody has an episode of incontinence, staff might be more negative towards that individual. They might not be allowed back at the particular shelter. Oftentimes that's not something people are wanting to manage, especially in the shelter setting. We also know that the data shows that about 30% of older adults experiencing homelessness have difficulty in at least one activity of daily living. What I will say, and the caveat along with that, is that it is not necessarily just the physical skills of the person or cognitive skills, but it is in part many shelter settings are not fully accessible, especially to those with mobility and cognitive needs. And then finally, shelter spaces are not necessarily designed with the needs of older adults in mind. For example, in order to have a high number of beds, shelters often use bunk beds, and those are inaccessible, especially to older adults or folks with mobility challenges. There's also significant barriers to accessing skilled nursing and long-term care, even if the person needs it. Folks experiencing homelessness experience discrimination and are barred from accessing this type of care based on race, based on their housing status of whether or not it's documented that they're unhoused or experiencing homelessness, because they might have a history of behavioral health needs or have ongoing behavioral health needs. This discrimination occurs even when the behavioral health needs are treated or stably supported by providers, and also because of insurance coverage. So many long-term care facilities only have a certain number of beds for folks who are covered by Medicaid, and most of their beds are reserved for those with Medicare. What we know is that older adults under the age of 65, so many in their 50s, are not covered by Medicare and only have Medicaid coverage. And so because of that, folks are unable to get into skilled nursing and long-term care facilities. And unfortunately, this means that folks are not able to access the appropriate level of care, whether this is following a health event or to support long-term care needs. Additionally, for those that are able to access skilled nursing or long-term care, once they're in those facilities, oftentimes there's a lack of trauma-informed care or harm reduction practices. They're not integrated with behavioral health care or are more challenging to manage somebody's behavioral health symptoms. And this creates challenges for folks in being able to engage in care once they're in the facility. Skilled nursing care is sometimes short-term, and folks may end up leaving early because they're not allowed to do certain behaviors or because their mental health needs are unmanaged. We also know that there's a lot of barriers to accessing housing. So in housing prioritization systems across the countries, those are often focused on prioritizing folks who demonstrate different frailties or vulnerabilities. However, when somebody is prioritized at the top of the list because they have that high vulnerability, then providers are concerned about their ability to live independently in units. And so folks might rise to the top based on need, but then there are concerns about whether or not they can do that. And often folks are then stuck in limbo, sort of waiting for housing, for folks to allow them into housing, or they don't move into housing and are back on the shelter in the street until their needs are so significant. Again, they need to move into long-term care or institutionalized care. We also know that the VI SPDAT, which historically has been used across many communities, prioritizes white individuals over BIPOC communities, which results in those who are not white staying homeless longer and contributes to chronic homelessness, which then we know contributes to significant health disparities and conditions. And so that then results in people being sicker and having decreased health by the time that they are able to access housing. And then finally, there's also a lack of harm reduction housing, right? So in terms of public buildings, there may be rules around folks who are not allowed to smoke inside their units, buildings that require people to not use substances. But what we know, this may then bar folks who are older adults, because as somebody is older in life, they are less likely to decrease or end their substance use, especially if they've been using for a long time. So folks might not be able to meet those rules and regulations to stay within that housing. And we also know that housing costs are a significant barrier. So as pictured here in the graph at the very top, that is the rent that is affordable to somebody who's relying on Social Security income, which older adults are more likely to have. Affordable rent for somebody living on Social Security income is $250 a month. As most of us know who are living in communities, that is not the average cost of a one-bedroom apartment. That's depicted in that first yellow line here that shows that a one-bedroom fair market rent apartment goes on average in the US for about $1,100. Of course, that might be greater depending on the community that you're in. So that is a huge, about a $900 difference between what housing is available versus what folks can afford. And when we think about affordable housing and housing vouchers, there's only about enough affordable housing to meet a third of the demand currently. And when we're thinking about the needs of older adults experiencing homelessness, only 1% of that housing, of that affordable housing, is wheelchair accessible, and less than 5% of that housing can accommodate even a moderate mobility disability. So someone who might be using a cane or a walker as opposed to a wheelchair. So there's not enough affordable housing, but there's also not enough housing where people can safely access and move around. And then older adults may have additional needs for supports that older adults who have support networks and resources and housing may have access to. These are not available for those who are older and moving into housing from homelessness. This again might be income supports in terms of vouchers or rental subsidies, accessible units as we just spoke about. And then maybe if somebody does move into a unit, but it's not equipped for aging in place. Even units don't include basic things such as grab bars, right? Which can make it much safer to do your ADLs. Neighborhoods are not always accessible in terms of having public transit stops close by or that are navigable. The sidewalks are clear for people to be able to get there with benches where people can sit. And then there's also not supports for more complex IADLs. So things like support for grocery shopping or deep cleaning of the home are not available for folks as they move into housing, but would help them maintain their housing successfully. So now I'm going to pause for a minute and I'm going to turn it over to my colleague, Courtney Platson, who's going to introduce herself and start our conversation around some strategies and promising practices for older adults.
Thank you, Caitlin. One of the things when we're really thinking and framing out how do we strategize to address this really large and growing problem is trying to build a continuum of housing and a continuum of healthcare. And so part of what that requires is us to break down silos and extend our arms from both systems. So often we're used to functioning as a hospital concretely, and then community-based settings, and then in long-term facilities. And how do we extend ourselves and our programs to coordinate better across these systems? How do we, on the homeless side, create systems from shelter to housing without having people have to exit one system to be able to enter into another? And so part of what we're going to be discussing, some of these strategies include really trying to improve some of the delivery of our systems and coordination across systems. Next slide, please. So we don't want to just have folks aging in place. We want them to age in the right place. So part of this is really thinking about intersectionality of affordability, accessibility, and harm reduction in the community. So it's not enough for housing to be affordable if it's not accessible. And if it's not accessible and it's not harm reduction based, that will exclude a large portion of this population. We know for folks experiencing chronic homelessness or people experiencing homelessness in general, about 30 to 50% of people have been diagnosed with a substance use disorder. We know over 50% have been diagnosed with a mental health illness. And so we need to make sure that we're actually designing programs for the people we are intending to serve. And when we create high barriers, we're only going to continue to exacerbate this challenge. And so permanent supportive housing and housing first, which really is a philosophical approach to housing that has had 30 years of robust research saying people have the right to housing and shelter, and we should support them getting into housing and then provide wraparound services and not require sobriety and engagement in services as a precondition for housing, but saying that it's really hard to stabilize someone's health, mental well-being, or substance use if they're experiencing homelessness because of the trauma and stress associated with homelessness. And so how do we make sure that we're not just putting people into housing and then saying good luck? It really requires these wraparound services in consideration of accessibility, affordability, and harm reduction. So the second is developing a safe and affordable supported housing models within community spaces. So often when we see older adults experiencing homelessness, they are incredibly socially isolated. Often they have no family or they've been disconnected from family and they have no social safety net. And so when we're thinking of aging in the right place, another consideration are things like group homes or assisted living facilities where folks can have community and develop and foster community and develop that social connection. We know that social isolation is a predictor of health. And so if people are interested or want to be in a group setting, we should be able to find places to support them to address their unique needs. And then another big challenge in the solution would be advocacy for access to long-term care facilities. So as Caitlin outlined, a big barrier is that many of these long-term facilities require sobriety, and they have the ability to deny people who have a history of mental illness and homelessness, which we see often. So part of this challenge is really helping these facilities learn, grow. How do we as systems have carrots and sticks? How do we encourage growth to embrace these patients? How do we provide the education? And then how do we on a system level require that of these facilities? Say, this is discrimination. We cannot discriminate or deny based on these services. And how do we require the integration of behavioral health in long-term facilities? Because the reality is that these folks are aging. They're aging beyond their biological age. They require additional assistance and support. And if someone's having cognitive decline in an independent living situation, like they're in an apartment, we don't want them to return to homelessness because they can no longer address their activities of daily living if they can't bathe themselves, feed themselves. But this is what we're seeing. We see that these permanent supportive housing programs or housing first are saying you're no longer safe to live in housing alone, which is legitimate. But then there is no other option. There is no continuum. When we try to refer patients for long-term facilities, they're either getting denied or there's wait lists that are years long. And so there is another drop-off. After someone's already experienced long-term homelessness, they finally get into housing, they're getting displaced again. And we're seeing people fall back into homelessness when they're the most vulnerable, the most frail, and then they're getting back stuck in that cycle. And so this is a really particular challenge that we really need to require and build out these health systems of our long-term care facilities to do this work better, to integrate behavioral health and harm reduction into their services. And there's a lot to learn from our homeless service systems. Our shelters do this well. Our healthcare for the homeless programs do this well. How do we provide the training to these services, to these centers to say you can do this and you can do this well? This doesn't have to be something that you have to deny these clients. So we really need them to do more and to reach out and partner with us. Next slide, please. One of the things I wanted to pause, we've been saying the word harm reduction, and I wanted to define that a little bit further. So harm reduction is often used very specific to substance use, but often what we're talking about here is really a philosophical approach to care that really establishes individual agency and self-determination as the central part to all efforts towards well-being. Harm reduction approaches call for the non-judgmental, non-coercive provision of services and resources to people who use substances to assist them in reducing harm or to reduce harm of other health behaviors. So really, harm reduction can be applied to any health behaviors and health choices. Harm reduction based care is collaborative. It provides education on available interventions and centers the goal of the individual in care planning. So when we think of integrating harm reduction principles, we want to think about how we integrate these into our senior housing, geriatric care, and like I said, with long-term care. And this can look really different. It's for that person that's been drinking for 40 years who has cognitive decline, it's asking what are their goals around their substance use. And for many individuals at that point, they don't want to stop drinking. And so how do we reduce the harm of that choice? So I'm a family medicine provider and I specialize in substance use treatment. And part of that conversation I have with my clients is, I don't want you to experience withdrawal. I don't want you to experience seizures and end up in the hospital. But I'm concerned through intoxication that your cognitive decline is really causing harm. And one of the interventions is a medication, for example, like not naloxone. I'm forgetting the word at the moment, but there are medications that can help them reduce their cravings for alcohol. It's not requiring absence of them, but it helps them reduce that really high volume that can cause harm. And so how do we meet them on actually having them identify their goals of saying, I want to hang out with my buddies, I want to be able to go to these activities a few times a week, but my impairment from my intoxication is preventing me from getting there. But I'm not quite ready to stop. Naltrexone, that's the word. And so that's part of my conversation with them. I was like, well, let's consider naltrexone. This will help decrease your cravings and help you maintain a functional status where you can get those goals done. And so that's really meeting the client where they are and understanding what their goals around their substance use and their social and behavioral desires are. The other piece of a strategy to think about is creating a continuum of housing. So housing first is harm reduction-based housing that accepts people kind of regardless of where their use is of drugs, of alcohol, and provides housing. Sober living requires abstinence. What is hard is that for many people with substance use disorders, if the use is across a full continuum from active chaotic use to no use and everywhere in between. Sometimes when someone is in housing first, they're working on their recovery and they actually want to get to a point where they're abstinent and that is their goal. But they would have to give up their housing to get into a sober living. And often that would require losing housing to enter into another housing system. And similarly, if someone is in sober living, if they relapse or they want to start using substances again, they're often evicted and have to become homeless before being able to access housing first. So how do we acknowledge that the rate of relapse is very high and that the goals of substances and abstinence change, but people shouldn't become homeless again? People don't deserve to be homeless over that choice either way. People deserve housing. And so part of what we want to do is really think of strategies of supporting folks maintaining housing regardless of where their goals are around their substance use. And then lastly, I just want to introduce this concept of palliative care and harm reduction. So I've worked in federally qualified health centers for 12 years, and part of my role as a primary care provider in the Healthcare for the Homeless Clinic was to provide outreach to our Housing First sites. By the time many of the patients are housed, they experience chronic homelessness. They're incredibly ill. They often have advanced illnesses of end-stage liver disease or COPD or CHF and end-stage health decline due to substance use. And so part of the challenge is now we've taken, of a sick population, we've taken the most sick or the most vulnerable and housed them. And often by the time that they're in housing, they are, like we've said, start to have decline or they really require additional services. And so part of what my philosophy or approach is not only a harm reduction approach, but palliative care. And not that they're going to die within 6 months, that's hospice, but how do we say, we want to maximize your time in this unit? You experience homelessness for a long time. How do I make sure I'm not adding a really high pill burden of all of your medications? How do I say, what is prioritizing their treatment based on their symptom burden, and not only just on like, we're going to do all the cancer screenings and we're going to put you on the cholesterol medicine that could prevent a heart attack 20 years from now, when they really likely don't have that many more years to live. So how do we really change some of our perspective to say, tell me, what are your goals? What are the things that really improve your quality of life? And how do I try to come up with the care plan, especially around their health conditions, that is the most simple, that is not burdensome to them, and really is focusing on them in their well-being and optimizing every day them feeling their best selves. And so it's a little bit of a change of perspective, but it's really meeting patients where they are and trying to provide all the wraparound services needed. So I saw a question in the chat around how do we bring in some of these additional services? And that is really part of building that continuum. How do we leverage and bring in PT, physical therapy, occupational therapy, speech therapy, visiting nursing? These are all different resources that we can refer clients to provide care in the home to help facilitate people aging in the right place. But many of those folks, the challenge is that they have not received training on this population. And so for folks experiencing homelessness, they often struggle with trimorbid conditions. So they have chronic health conditions, they have often disproportionate mental illness and substance use disorders. And many of those treatment providers have not received training on those conditions. They haven't learned about trauma-informed care or harm reduction. And often they can be discriminatory, or their agency might have policies that are discriminatory that says if they show up and they see a beer, then they can't provide their physical therapy that day, even if the person's not intoxicated. And so when thinking about how do we extend programs and services, how do we help to build that continuum, I encourage you all to partner with these agencies. How do we cross-train? How do we have your experts train those clinicians? Because I'm not a trained occupational therapist or physical therapist, but I am an expert on trauma-informed care and harm reduction and caring for people experiencing homelessness. I can go and do trainings to those groups. How do I help actually address some of their policies that they have just chosen that we can modify or change? How do we help bring in some behavioral health and substance use support into the housing? So having peers, offer a variety of groups, smart recovery groups or AA and NA in those spaces so that clients can opt into those services if they desire. Partnering with your behavioral health providers to provide care on service. So these are really ways that we can provide these integrated healthcare services. And like I said, I used to provide care on site to clients. So many FQHCs have public housing-based settings, and Healthcare for the Homeless programs can continue to provide that outreach to these facilities. So how do you reach out to a partner? So when we're thinking of cross-sector partnership, if you are a housing provider or a shelter provider, you can reach out to your local Healthcare for the Homeless clinic to say, is there a provider that could provide services on site? Our clients are having a hard time getting all the way across town because of mobility or accessibility challenges. Many programs have shelter-based programs or housing-based programs, and if they don't, maybe it's an opportunity to partner. So these are just some things to consider. If you're on the healthcare side, how do you decrease barriers and bring care to where people are? If you're on the housing or shelter side, can you reach out to your healthcare partners to say, can you bring care to where our patients are? And then lastly here, identifying in the hospital or while clients are in inpatient settings, those that are at risk of housing loss following a significant medical event. So Caitlin describes a cascade as if someone has a major medical event like a stroke or a heart attack or surgery. They might be in the hospital for weeks to months, or it might go from the hospital to a long-term rehab. And in that time, they lost their employment, they lost their health insurance, and they become homeless, they lose their housing. And so how do we identify very early in that hospital stay the cascade that's about to happen? Maybe there's rent relief, maybe there are additional programs, maybe they can apply for Social Security disability, but how do we bring in and partner with social services in the hospital before it gets to the last week of that rehab and that person is being discharged to a shelter? It's much easier to prevent homelessness than it is to address the housing once they're homeless, because it ends up with multiple year wait lists. So as much as we can do homeless prevention, it will make a huge difference for that individual and hopefully prevent homelessness in the first place. So I really encourage you all, if you have a client that's hospitalized, if you have someone that you know is had a major medical event, work with that inpatient team to figure out how we can address benefits or benefit acquisition or housing support before they become homeless to prevent that cascade from happening. And I'm going to turn it back over to Caitlin, and I'm going to jump back in the panel. Thanks, Caitlin.
Great. Yeah, thank you, Courtney. And again, just sort of introducing some of these strategies, and a few of our panelists have even more expertise on this, but one of the huge pieces is thinking about accessibility, both within shelter spaces, but also within the housing options that we have within our communities. So as noted, again, less than 1% was accessible to folks in a wheelchair, and less than 5% of affordable housing is accessible to folks with even just moderate mobility needs. And the unfortunate part about all of this is that some of these fixes are very simple and do not require a substantial amount of money or technology or things to be able to use. There's a lot of simple removable in-home modifications that can make the space more safe for the person who is living there and supporting in that transition. And you don't have to figure that out. If you're on the housing spectrum, you don't have to figure that out alone. If you're renting out units, again, there's specialists in the community, again, such as occupational therapists, that can be really great partners and team members. And will require a little creativity, because what is doable within rental units is a little bit different than when the person is owning the home. However, minor modifications are covered part of the Fair Housing Act for people to be able to do that, to be more safe within their spaces. One of the significant barriers to this is cost. So many types of durable medical equipment are not covered by Medicare or Medicaid. Things like grab bars or shower chairs or non-slip bath mats that all prevent falls. Night lights within somebody's room. And unfortunately, then that's cost prohibitive for people to be able to put those in their home, even if their landlord is willing and they have someone to support them in doing that. So one of the pieces we need to think about when we're thinking about subsidies and income supports is how do we get folks these needed resources and supplies? And in many cases, there are resources in communities such as Easter Seals or other places where folks can borrow the equipment long-term if needed. They repurpose it after somebody doesn't need it anymore. It can be donated, or even just building out a funding stream to help folks access these resources. A basic shower chair costs less than $100 to purchase. So we're not talking about super expensive medical things, but can make a huge difference in terms of preventing falls and somebody's quality of life once they're in housing. And then we also need to increase accessibility of transitional shelter and regular shelter spaces. Again, shelters do not always meet accessibility needs, but simple changes can really make a huge difference for a lot of folks in being able to safely complete their ADLs within shelter. So a lot of times, again, the assumption is that it's the person who is not able to do their their ADLs, but really they're not doing their ADLs because it's not safe, right? And they may opt to wash up by the sink because they are unable to use the shower. I worked with a client in the shelter setting who was showing me the accessible shower. She required the built-in shower bench. She couldn't reach to turn on the faucet once she was sitting on the bench. There was not non-slip guards on the floor. There was not grab bars for her to hold on to. So she could not safely turn on the water while seated. And because of her mobility needs, couldn't stand and walk. And so very simple fixes like that to make spaces more accessible will meet the needs greater of folks who are older adults while they're waiting for housing. And then I also want to just spend a moment talking about social connection. When we're thinking about housing, especially for older adults, when we're creating housing first permanent supportive housing spaces and communities, or even thinking about where we're making units accessible and available for folks, how do we have space and opportunity for social and peer interaction? Older adults are more likely to experience social isolation. We know that older adults experiencing homelessness are even more likely to experience isolation and community isolation. This is not uncommon for those who've been experiencing homelessness when they move into a new neighborhood or community to feel isolated and to feel not engaged and integrated into their community, both because of bias and stigma, and also just due sort of to the trauma of that disruption of homelessness and into housing and getting familiar in their space. So having some structured supports set up to address this particular issue can address mental health needs, and again, that quality of life piece once somebody's in their housing, and folks enjoy their housing more and are able to work through some of those difficulty and transitions when they have that social connection and social support. And again, we don't have to recreate things. It's more, as Courtney was talking about, building these community connections among these different entities. Many communities have senior centers. Do your clients in permanent supportive housing know about these senior centers? Can we build out a relationship so folks can go and spend time amongst their peers, doing things like playing pool and playing cards and just spending time together, taking small trips? Most of the time senior centers are very affordable, but do we need to advocate for some subsidies in order to allow folks with more limited incomes to be able to participate? Similarly, recovery groups, and making recovery groups that are focused again on older adults and more on their peers and their experiences, again, can help create and build that social connection. And then just to reiterate what Courtney said, really needing just collaboration across all of these different entities and sectors, cross-training, right, as she mentioned, so that older adults and aging specialists are able to train permanent supportive housing and shelter providers on the needs of this population. And at the same time, the folks who are working in homeless services can train those who work with older adults around trauma-informed care and harm reduction. We also might need some advocating around adjusting eligibility, again, because this population needs services a little bit younger than those who are housed, thinking about how can we adjust some of those ages so that folks are eligible for some of these supports that they might need. And then again, just thinking about, as we're creating and building more affordable housing, how do we build models that are effective for those who are older adults, both structurally in terms of supporting function, and then also that social connection piece. And there's a lot of community groups that do focus on aging in place, but a lot of times they're focused on homeowners. So how do we build that connection and restructure and build out an arm of that addresses the needs of older adults who are maybe renting, who don't necessarily have as much control over their physical space, but how do we still integrate some of those strategies in those spaces? And really make sure that we're advocating for fair housing. Simple things like installing a grab bar are protected by the Fair Housing Act because it doesn't impact the quality or value of the rental space, but landlords may deny that for a various number of reasons, and I've seen it happen in practice. So how do we advocate so that folks are not at risk for housing, but are still able to advocate and get what they need? So just planting some seeds to think about here as we turn it over now to our panelists. I'm going to turn it back to Courtney for introductions.
Thanks, Caitlin. And thanks everyone for your really thoughtful questions here. There are so many avenues and pieces for us to discuss, and I'm looking forward to talking through some of these. I am joined today with a really wonderful panel of experts. We'll ask first is we'll go around and have folks introduce themselves. And I'd love for everyone to just introduce yourself and then also share the lens in which you approach this work. We have folks that are clinicians that provide direct service. We have folks in government and research, and we want to think holistically about this problem As some of your questions have reflected, there's interpersonal challenges with really supporting an individual. There are system challenges in built environment and government and policy and everything in between. And so we really wanted to bring a group of people that think differently about this topic, that have varying expertise for us to leverage. So we'll go around and everyone can share a little bit about themselves and their approach to this work. I'm going to first turn over to Kavanya to introduce yourself.
Hi, my name is Kivanya Elzia. I am the Director of Justice, Equity, Diversity, and Inclusion at the National Healthcare for the Homeless Council. My background is actually in direct patient care. I've been in healthcare for over about 20 years, but I've been a registered nurse for the last 19. And prior to becoming the director, I worked in as a community health nurse on our street outreach team out in Seattle. And I was located in permanent supportive housing buildings. So I actually provided in-house nursing care to that environment.
Thanks, Kavanya. Shireen, I'll turn it over to you.
Thanks. Good morning, everyone. I'm Shireen McSpadden. I'm the Executive Director of the San Francisco Department of Homelessness and Supportive Housing. I've been there for 2 years. Previous to that, I was in disability and aging services for 30 years. And most recently, before this current job, I was the head of the Department of Disability and Aging Services in San Francisco. So I've done a lot of national and state work in aging. I ran the San Francisco Palliative Care Network for a number of years, and I'm still very, very passionate about older adults and particularly how we serve older adults experiencing homelessness.
Thanks, Shireen. Tara, I'll turn it over to you.
Good. Hi, everybody. I was going to say good morning, but actually it's the afternoon. I'm joining everybody today from the University of Utah, which is located on the traditional territories of the Ute peoples, and I'm grateful to have the opportunity to live here. I'm an associate professor with the University of Utah. I have a shared appointment in the College of Social Work and the Department of City and Metropolitan Planning, and I'm also the associate director for our university's interprofessional education program. I come today as a social scientist, a gerontologist, so really looking at the social experiences of older adults, their experiences of homelessness and housing insecurity, and really attempt to have my work center around community engagement and answering questions that are of importance to communities, which is essentially how I entered this space and why I'm here today. So thank you.
Thank you, Sarah. Caitlin, I also just want to give you the opportunity to talk a little bit about your work as an occupational therapist with this population as well, because I know you spoke about your role at the council.
Great. Thank you, Courtney. Yeah, so I'm an occupational therapist, and I worked at a healthcare for the homeless program that had a permanent supportive housing team, a medical respite program, and then integrated primary care. So working with folks across the spectrum of those services, and with permanent supportive housing folks doing a lot of work with doing those aging in place and helping people be able to live in the community of their choice for as long as possible, many of which were aging in those particular units. So looking at sort of the resources available and also the tensions in navigating some of that based on those barriers, but really trying to support folks in living in the community as long as possible.
And Caitlin, can you define occupational therapy? Everyone might not know what that means.
It's a great question. An opportunity for an elevator speech. So occupational therapy really focuses on helping people be able to do the things that they need to do in their daily life and really focusing on doing that in the community of their choice. So depending on the setting, it can range from focusing on developing skills to do ADLs all the way to some of those more complex tasks, such as meal prep, health management skills, community transportation, really looking at the spectrum, all focused on what the client desires and wants to do with their lives, and then identifying resources, strategies, and supports to be able to do that.
Thanks for sharing. I wanted to give her a moment to explain that, because I think many people don't know what an occupational therapist is and how valuable they can be at supporting this population transition into housing and being successful in housing. So thank you for sharing that. So I shared a little bit about my clinical role at as a primary care provider, but I'm also the clinical director at the National Healthcare for the Homeless Council. And in that role, support the health centers across the country, provide care to people experiencing homelessness, but part of my role is also to work across the federal government and to make sure that we're always thinking of this intersection of health and homelessness. So this topic is near and dear to my heart. So let's get into the conversation. I thank you all for being here this afternoon and morning. We also span 4 time zones. We're all across the country from East Coast to West Coast. So we bring lots of different geographical perspectives as well. So one of the things I wanted to first talk about is really thinking about those that are directly impacted. What are you hearing from your clients, participants, constituents, and those with lived experience about what their top concerns or needs are, those currently who are aging while experiencing homelessness? Maybe I'll start with you, Kavanya. Thoughts about kind of really top concerns right now in the community around this topic.
So I actually reached out to some of my healthcare for the housing healthcare peeps back here in Seattle. Like I said, we have our own housing health outreach team that are located in permanent supportive housing. And the things that came up for them was lack of consistent chore workers, bias, so lack of access to essential health needs. If one thing that even when I was back with them a little bit over a year ago, we could never get PT, OT, and speech. Like trying to get them to come in, trying to get a home health nurse to come in and see my patients on the days that I wasn't there was near impossible. If they had anything, if they had a substance use history, even if they weren't actively using, but if they had a history, if they lived in a building that was harm reduction, if they were on medical assisted treatment, so methadone, Suboxone, any of that, if they had quote unquote non-compliant behavior in the past, right? We could not get those services. Trying to get them connected with specialty care, also could not get those services. And a real need for tiered housing is what came up too. Like how, so that we can meet the needs of the people where they're at. And I'll go into that a little bit more because we did have an awesome team at one of the buildings I worked at where we stepped up and went above and beyond and provided in-house hospice care, in-house palliative care. But that's just because me and the case managers there, took that step on our own.
So when you mean stepped up, it's like as the clinical need increased, you provided additional services as folks to provide death with dignity in their home as well.
Absolutely. We had a patient who had bladder cancer, and he, because of his past medical trauma, and he's blind and he's elderly, he would not leave. He was very reluctant to even allow us to bring in-home hospice to him. He trusted us, and that's the only people he was willing to engage with. And so while I was there, I provided care for him during the day. When I left, I had taught the staff how to empty his Foley and how to do all the things that they needed to do until I came back the next day. We did. Mm-hmm. We stepped up and made that happen until it was time for him to transition.
That's really powerful, thinking of how we pair healthcare outreach with housing support. So thank you for sharing that example. Sarah or Shireen, thinking more on moving from direct service to really thinking more of systems, what are your thoughts about what are top concerns in your communities right now?
Did you just ask me, Courtney? Sorry.
Sure. Yeah. Go ahead.
Okay. So, I mean, I think one of the challenges we have is that the homelessness response system was not designed with the needs of older people in mind and didn't really think about aging in the first place. And so I think we're all caught trying to figure out how we improve our services by making all of these programs more accessible and really thinking about how to train staff in what it means to age in our system and really ensuring that our clients and tenants can age with dignity. And I think there are a lot of, I know we're going to talk later about solutions. There are a lot of promising things going on, but one of the big things, and this was mentioned during the presentation, is that we're just really starting to partner. So healthcare and the homelessness response system need to partner better. But in addition to that, I think that it's really important that we include the area agencies on aging, which are really the umbrella for the things like the senior centers and home delivered meals, but also play a big part in isolation and addressing isolation. There's just so much innovation there. And while there's not as much funding as there is in health for area agencies on aging, you know, local area agencies on aging have managed to do some really cool things and are starting to engage much better with people experiencing homelessness. And they have that aging expertise that the healthcare system has, but in a different way. And the homelessness response system still doesn't have primarily. So bringing all of those three together, I think makes a lot of sense. And I just want to add, like this morning, I was in a conversation with with the director of US Aging and Dr. Yolanda Stevens, who oversees older adult work for the National Alliance to End Homelessness. And these conversations are just starting to happen. You know, we weren't having these conversations 5 or 10 years ago.
Thank you for sharing that. It feels really important because when so many of our systems were often built in the 80s and 90s, the homeless population was much younger. And so it really wasn't designed to serve the needs of this population. And so I think that's a really important point in thinking, how do we not just adjust our services, but then really think about partnerships differently now? So that's really helpful. Sarah, I'd love to hear from you thoughts about how we engage people with lived expertise in this work too. How do we bring those voices to help drive some of these solutions? And how you're doing that a little bit? Could you share how you're doing that in your work?
Thanks, Courtney. I can. And I just want to add one more thing
Please.
too, that when we're looking at trying to find the right data on older people experiencing homelessness nationally, that the age breakdown doesn't actually give us a very good sense of the numbers and what we're seeing. We're able to capture it in some ways, but you know, a lot of this is just that our service providers are noticing this uptick in the age of clients and sort of scrambling to figure out solutions for this. And sort of as Shireen was saying, we didn't design services to meet the needs of older adults. And so yeah, I just want to mention that data point too, because it's, I think, a challenge for us making the case of the urgency of what we need for older people experiencing homelessness because of the lack of data that really showcases this. So in the work I do, one of the challenges I think we often interface with is not having peers or people with lived experience at the decision-making tables or at the tables where we're having conversations about solutions and what's truly needed. We enter into the solutions with ideas about what we think. We design things and then need to rework them in some cases to actually meet the needs of what people are telling us are their needs. And so I think in all the work that we do, it's really important to have advisory groups who are made up of people across the diverse identity factors of those who have experienced homelessness. So it's, when we think, and even when we think about older adults experiencing homelessness, some of us use 50 and older, some of us use 65 and older, whatever it might be. Well, the difference in age between somebody who's 65 and somebody who's 50 is vast. And then somebody who's 80 is even greater. And so just really thinking about intentionally including people's voices who have lived experience, whether it's in research, which is where I kind of entered, as I mentioned, the field, but also in the decision-making around the services that we're designing or the solutions that we're developing, I think is a really important part of that too.
Thank you, Sarah. I really appreciate that. And we're gonna talk a little bit more and dig into really thinking about equity and engaging people with expertise. But I also I see a question in the chat that I wanted to make sure we addressed. One of the questions was about traumatic brain injury, in addition to some of the other conditions and often the trimorbidity that people experience. And this is so important. Caitlin, I want to give you a little bit of space here to kind of talk through this. We know that people experiencing homelessness have very high rates of TBIs, and that certainly leads to advanced cognitive decline, and can exacerbate both mental health and substance use challenges, and can be really challenging to provide the right services in housing. But I just wanted to, Caitlin, if you had anything you wanted to speak to that kind of intersection in particular.
Yeah, absolutely. Yeah, the rates are about 50 to 75% of people experiencing homelessness have experienced some form of TBI. The data point that I always like to emphasize is that almost half of those individuals experience their TBI before becoming homeless. So speaking of that sort of across the continuum of healthcare, identifying folks who might be vulnerable to housing loss and housing instability after TBI is incredibly important, in addition to responding to that once somebody is experiencing homelessness. And yes, those are especially individuals who have cognitive issues as a result of the TBI. They also often have physical needs that happen. And so these are the folks that really do need that coordinated wraparound care engagement with different systems. And, there are brain injury specialty programs in communities that can make for great partners. So TBI waiver programs that exist across states. Somebody else spoke about elderly waiver programs can be another partnership for folks. The problem with those waiver programs sometimes is that the wait list is very long. But there are other community-based resources, brain injury associations and alliances that really know resources for folks that people then may be eligible for. So in terms of different service sectors, screening for that history of brain injury can be really important because it might not be documented and it might not be on recent medical records, but could open up potential resources that folks may have access to get some of these additional support systems. But for all of this group especially, it really emphasizes the need for not just physical accessibility, but cognitive accessibility for folks to be trained to understand that there may be people with memory issues and attention issues, and it's often misperceived as a lack of motivation to engage in care or to follow through or to adhere. I put all those words in quotes because I don't like them, but really it's a result of how the person's brain is working. And when we learn how to do those accommodations, people can be much more successful in our systems and in their housing. And so that really, it's sort of that universal accessibility piece that Sarah was talking to. If we make it accessible for folks with physical needs and cognitive needs, then it's really going to be accessible for everybody. And that supports that aging in place piece.
Thank you, Caitlin. I appreciate that. I do want to move into talking a little bit about some promising practices. I know we've outlined pretty well a lot of the barriers and challenges that every community is facing. But there are there's lots of amazing work happening and some really wonderful examples. And everything from integrating health and housing, thinking of ADA accommodations, medical respite, thinking of how we really infuse health equity. So I want to kind of bring in these various lenses to thinking about promising practices. So Shireen, I wanted to give you a moment to kind of share some of the work that you're doing in San Francisco and where you see some bright spots here.
Sure. So I think there are a few things that we are doing, and one of them really just kind of adds to what I said before, that we are working very closely with our Department of Disability and Aging Services to make sure that we that we're working in sync. The one big thing that we've done over the past 2 years and really in this last year is make sure that our in-home supportive services program is available in all of our PSH sites. And we started with the ones that have the most older people and people with disabilities living in them. California has a really robust IHSS program. In San Francisco, we have 25,000 people on IHSS, and we really use it in the broadest way possible. Not every county does that, and I realize that states have different programs.
Do you mind just explaining what that an acronym is?
Sure. So in-home supportive services is home care. In California, the way it is, it's a Medicaid program and it's an entitlement. So many people in California have access to in-home supportive services, and social workers come out and assess and decide how many hours somebody qualifies for. It was predominantly used for people in their own homes for a long time, but PSH is your own home. And so it is actually very effective in permanent supportive housing, just like it is in anywhere. And then there's also ways to use that program in shelter. And so, we've been doing that a little bit too, and just to make sure that people have the home care that they need wherever they are. So that's a big partnership that we have with the Department of Disability and Aging. The other is really making sure that even if somebody's on the street, and we have unfortunately limited resources, that we're really thinking differently about people's vulnerabilities and using our coordinated entry system differently, so that those, we were having problems with that system where we'd have somebody 85 on the street who didn't, rise to the top in terms of the acuity, because the system was not correct. So we've really been working on that to make it better, but also, again, working very closely with our Department of Disability and Aging, because they actually do have housing resources sometimes and access to assisted living or longer term care solutions that we don't have. And sometimes people can bypass our system and go directly to there. So I think, again, that partnership is really important. We have one new building that is permanent supportive housing. It's actually two buildings together, and one is specifically for older people, and there's an FQHC on site. And we have a roving team from our Department of Public Health that sees people in that building. And so that's a really good partnership that we have with a variety of partners to make sure that we're really focused on the healthcare needs of the people living in the building. And then the Department of Disability and Aging is working with people in that building to make sure that they're connected to social services in the community as well. And then the final thing I think that I could say that is very promising is that there's a model in Oakland where during COVID, they took a shelter-in-place hotel, one of the hotels that was stood up during COVID to support people most at risk. And they're moving that into a permanent supportive housing, but really providing all of the wraparound services needed, and kind of goes back to what Kavanya said earlier, that, they're able to bring in the health professionals for people to get palliative care, to get hospice care, to get care to rehab, all of the things that you see in more long-term care systems. And we're actually looking to do that in San Francisco as well, and create a like model in San Francisco based on what they did.
Thanks so much for sharing those examples. One of the questions I saw a lot in the Q&A is many departments of aging don't specialize in supporting people experiencing homelessness, even if they're older adults. Often it's for people who are housed or well socially connected. And I'm curious your thoughts or ideas about how do we really partner these systems? How do we work well across the homeless service system and the departments of aging?
Yeah, and that is why I referenced that conversation I had this morning with Sandy Markwood, who's the head of of U.S. Aging, and that they're the ones that are the kind of the trade association for the area agencies on aging. And I very much leaned into that partnership when I was the director of aging in San Francisco, and we're seeing that more and more. But we talked a lot about the importance of helping the area agencies on aging really establish those partnerships and understand what they can bring to the table, even if they don't have a lot of funding. Like in San Francisco, there is funding. There's a lot of local funding, but for places that don't, there's still a role to play. And so we are going to be jointly working on that kind of at the national level to make sure that all the area agencies on aging understand what that role should look like and how to reach out to the COCs and the other partners that they should be working with.
That sounds great. And if there are other webinars or resources that come out on that national level, please share with us and we can disseminate to this group too, because that sounds really promising. Thank you. Sarah, I wanted to turn it over to you to share any ideas you have on promising practices or bright spots that you've seen.
Thanks. And I'm trying to keep up with all the great questions that are coming in the Q&A. So I want to talk a little bit maybe about medical respite as a promising practice broadly. And I know some communities have great examples of this. And so one of the comments, I think one of our participants, Allison Cole, made a comment that's a good one, that we see examples of hospitals developing these medical respite programs to support people who don't have safe, secure places when they're being discharged from a hospital, where they can spend time to recover from whatever health conditions that they're recovering from, get the antibiotics that they need, get the IVs that they need. And there's also temporary housing program models for individuals who can live independently. So this wouldn't have medical supports attached to it, but really giving people some time to organize, whether it's the income supports that they can tap into that they might not be accessing or might not have all the paperwork filled out, or other documents that they would need in order to access subsidized housing units or voucher programs. And so giving people the time and space to recover and recuperate, I think is a really great model for supporting people to get into, like what we're talking about today, the right places for them based on their individualized and unique needs. So I think there's a good number of medical respite programs, but I don't know that all communities have them either. So that would be one that I just think we should maybe talk about as well, and hopefully reflect some of the answers that people are talking about asking about in the question Q&A.
Thank you, Sarah. And I thank you for that, because medical respite is part of the work that Caitlin and I do at the National Institute for Medical Respite Care. So first, I'll see if I'll add a link to the National Institute for Medical Respite so you all can access those services. But there are about 130 programs nationally. 130 in our country is obviously way too few. But medical respite really helps to provide that continuum of care for people experiencing homelessness who are too sick or frail to recover in the street or the shelter, but who don't need to be in a hospital anymore. But we know folks experiencing homelessness have very high recidivism rates back to emergency departments and back to inpatient, because it's really hard to heal and be well in a shelter setting when you've just experienced an acute illness. And so medical respite can really fit that unique need. There are many models across the country. Some are partnerships between FQHCs and hospitals. Some are partners between shelters and health centers. There are many different types of programs. I'm going to share, when we share the link, or Caitlin, I wonder if you could drop it in, you can look up the directory to see if there are any medical respite programs in your area. But often at NIMARC, we are doing lots of different webinars to talk about how to start medical respite, funding for medical respite, and there's a lot of really wonderful resources. If that is something that you have that need in your community, we have a lot of support that we can provide you to help get that program started. I helped to support and open a program here in Portland, Maine, the first medical respite program in the state. It just opened in September, and it took 5 years to open, but it finally did, and it's making a huge difference in the lives of our patients. And so it is such an invaluable intervention for people to be able to really get that opportunity to stabilize their health with what Sarah described as really those wraparound social services that people aren't able to access in the hospital. While they're in medical respite, they can go and apply for Social Security. They can get assistance getting to those outpatient appointments. They can establish longer periods of sobriety so they can enter into sober housing if that's what they want. It just opens up a lot of other opportunities for people, and can really, so months of social service work can be done in a few weeks in a medical respite program, where if someone's experiencing homelessness, those competing needs of just needing to access food and shelter make it really difficult to attend a lot of different appointments. So it's a really impactful intervention that really decreases length of stay in the hospital and improves the quality of life for the participants. Caitlin, anything else you wanted to add about medical respite?
I think you covered it a lot. I will just emphasize again that our website has a ton of different resources to help support building medical respite, and we are accessible on there. There's a contact me form, but if you'd like to speak with us more individually about it, please use that, because our team would love to work and support communities in opening respite across the country.
Great. Thanks so much. One of the things that I wanted to make sure we think and talk about is really health equity in this space. And one of the things that Caitlin mentioned that there were a lot of questions about around how the VI-SPDAT is skewed and biased and disproportionately with housing or prioritizing white folks compared to BIPOC communities. And there's been a lot of research in response to that around how we can create coordinated entry systems. Just to what others were saying around folks that are much older and what we would in one-on-one saying this person is very vulnerable, but not well reflected in a VI-SPDAT. And there is no perfect tool. I mean, I just want to say that like no one has created the perfect way to assess vulnerability and risk for housing. And the issue is that we have a scarcity of housing. There isn't enough for everybody. And then we have to create these systems of prioritization, which is really crummy because everyone deserves housing. But I really wanted to think about talk a little bit about some promising practices of how we think of equity in the space of housing, equity and aging. And we know that people of color disproportionately experience homelessness. So how do we create systems to address homelessness that are equitable in accessing shelter? Kavanya, I wanted to see if you had any thoughts as our JEDI director. I know you have many, but where would you like to start on this?
Where I would like to start for health equity is I need people to check their mindset. In the chat, I saw so many questions on how do I get them to do this? And I'm like, stop, I need you to reset. Check your mindset rather than turn into judgment or I need to fix you. I need you to turn to curiosity, right? No little person woke up one day and was like, when I want to grow up, these are the struggles I want to have, right? Like nobody chose this life. And yet the reality is it exists. And so figuring out what is that narrative behind that, right? Figuring out why they're not willing to engage. What is the narrative behind their lack of desire? Most likely it is trauma. There's so much medical trauma that goes on. A perfect example that was shared with me, again, from one of my hot nurses, so that's a housing health outreach team nurse, is she had a patient who's 73 and they have the trifecta of congestive heart failure, COPD, and asthma. And so frequently every 4 to 6 weeks end up in the hospital with pneumonia issues and has a long history. Remember, they're 73. They've been smoking crack since they were 13. And during their most recent visit, a nurse told them that if they took the antibiotics that they're being prescribed for pneumonia, in addition to continuing to smoke crack, that it would have a chemical reaction and that would kill them and they would die. I'm like, no, scare tactics will not work, right? Suspend your judgment, figure out what really needs to happen. So that's number one. The other thing for health equity and best practices is housing health programs. We have a fantastic aging and disability program in the Seattle area. And we had a case manager that was assigned to us. So Serene, when you were talking about that, I was like, oh yeah, Leo was awesome. He was assigned to multiple permanent supportive housing buildings and would come to us and help us navigate the bureaucracy of that system so that our clients could get what they needed. Having case managers, we have a mobile cardiac team that is with one of our level 1 trauma hospitals. And because they typically see our patients the most, they were like, we're going to create this mobile team. And they come out to us. They come out to the permanent supportive housing building so they can be seen by the cardiac nurse practitioner and have the care provided, because we know it's hard for them to get to appointments. Again, rather than judging them, right? Rather than punishing them for the struggles that they're navigating, how do we address it, right? How do we make these decrease barriers in open access? Somebody mentioned a question like, what can peer supports do? You can partner, you can do activities. Loneliness and depression is a huge thing in this population, regardless of age, but particularly as they age and they get older, because they die more quickly than their counterparts, which Courtney had mentioned, right? Which means these individuals are losing their friends. They are losing their community on a regular basis, whether to overdose or chronic illnesses. And so peer supports can be those people that come in and provide that community, provide those activities, can provide those support groups and actions of support, which have such a huge impact on health. Mobile health, mental health teams, also huge thing. Yeah, and there's tons more, but I'm also being mindful of time.
I'm so grateful that you mentioned name some of the mistrust or those that are, often labeled non-compliant or are not engaging in services, because I just want to highlight that for many of these folks, they experienced homelessness for years, decades at times. And for many years, they've been told by various teams that they're going to help them. And for many years, they continue to experience homelessness. And I'll share this, not to be political, but one of my patients, when I was doing outreach I was doing street outreach and serving folks and finding folks that were staying in encampments in the woods. And an election just happened. Obama was our president, and then Trump was being inaugurated, and I was in DC at the time. And the patient, I was just talking with him, and one of the things that he said that really struck me was, I was homeless under Obama, and I'm going to be homeless under Trump. And that kind of really made me go back on my heels around, we often as healthcare teams or social service teams want to promise services. And those clients have probably heard many promises over the years. They've had many well-intentioned people trying to help them, but we have scarcity of housing, and they've continued to not get their needs met and experience homelessness for a long time. And so part of this is a protective mechanism. Part of this is, I have experienced a lot of hurt and trauma over time, and that can really sow mistrust. And those are self-preservation mechanisms. And so often it can take months to years to build trust again. And so just want to offer that. And of course, adding in some of the cultural complexity and race and gender complexity, all into these intersections into mistrust. But I just want to say, I know that it can be challenging when someone is facing eviction over a behavior, but all that we ask is that you continue to care for people with unconditional positive regard. That's the most impactful thing that you can do. Continue to provide compassionate care and help to not add trauma or add harm, but really just sow trust and be consistent and transparent and not overpromise, because I can't promise someone housing in this crisis right now, which is really crummy. But I can continue to outreach them on the day that I say I'm going to outreach them, and I can say I'll do that application and follow through on the pieces that I have control over. But I think that's just a particular challenge that I appreciate you bringing up, Kavanya. One other thing that we've talked a lot about that I just really want to highlight, and of course, because I'm a healthcare provider, we've talked a lot about different ways that healthcare systems can intersect with housing and our social services. One of the things that we saw many comments about is the challenge accessing specialty services, PT, OT, speech. And then even in the long-term care facilities, people saying, yeah, my patients get denied. There are lots of particular systemic barriers to those, but I just want to spend a few minutes of seeing and talking about where people have seen success in that. I think there's different funding mechanisms, there's partnerships, there's relationship building, there's lots of different pieces. One of the comments mentioned, really, rather than having these clients navigate these various services, really co-locating all these services. But I just want to kind of end on that topic of really, that's one of the particular barriers for this intersectional issue. And I just wanted to see, Caitlin, if you had any ideas for how to better partner across these specialties and how to really integrate these services within housing or homeless settings.
Yeah, absolutely. First of all, I think if you are able to, integrating those services as part of your health center permanent supportive housing medical respite program, because then they are part of the team, and that really supports that communication and team-based care. I know that there are some billing and funding challenges around that, but when we're thinking about outcomes for folks, that can be really incredible to have an OT, a PT, on staff that are really focused and know how to do these things and understand the community that they're working with. With that in mind, I think when that's not feasible, building those partnerships and collaboration. Things like harm reduction, trauma-informed care are not necessarily central to OT and PT training, although that's becoming more prevalent. But as Courtney mentioned, that cross-training, cross-collaboration, identifying the home health, the palliative care, the hospice program that is interested and ready to work with your clientele, and identifying who those providers are and making those connections and doing some training on that and opening up those communication lines and helping people understand what these services look like and that you are this person's support system, and shifting that mindset a little bit. That's growing. I'm at our national conference this week, and there are 6 sessions on working with people experiencing homelessness, which is incredibly exciting. There used to be 0. So I think that the appetite, the interest, the need is growing. And so I think that's a great time to capitalize on building that partnership so that if you can't create what you want, you can utilize what might be there, and building those relationships together.
And I just want to open up for each of you. If there's a particular topic that you wanted to discuss that we didn't get to, I welcome you to come off mute and share. If there are particular parting words or thoughts that you want to make sure that are points you really want people to walk away with, I welcome. So Stefania, Sarah, Caitlin, or Shireen, whoever would like to chime in.
I would just, go ahead, Sarah.
I'll just start real quick. It's not a solution, but I think it's something that, we have a good number of participants. As we're thinking about solutions, one of the things we haven't had a lot of time to talk about today is really the underlying discrimination towards people experiencing homelessness as a distinct form of discrimination, and ways in which we can work as community members, regardless of our professions, but as community members who are voting members within our communities towards dismantling that discrimination. Because one of the the answer to homelessness is housing, and we hear a lot about NIMBYism or pushback against affordable housing projects. And at the core of that, I think there's some underlying discrimination. So I just want to add that as an additional sort of overarching challenge that, if people are feeling like, what can I do? It's like, talk to your local legislators, your decision makers. And when people are pushing back against affordable housing, be the YIMBY in the room, be the yes, I want this in my backyard. So I'll just leave with that. Thanks for the opportunity.
Thanks so much, Sarah. Really appreciate that. Shireen?
I would just say that I think we all have the responsibility to really think about what equity means in our system. And we know that we're seeing more and more older people in our system, but also those people tend to more and more be people of color, Black and brown people. And and this is my own local lens, but we don't have enough organizations that are run by the people we're serving and that look like the people we're serving. And we really have a responsibility, I think, to uplift those organizations that do, and really support organizations that hire people with lived expertise of homelessness and people who are aging in the system. I think, I've certainly seen that when we support those types of organizations that we get better outcomes. And I think it really goes back to the isolation piece. I mean, I think people need to be around people who they feel like they can be in community with. And I just think it's really important that we think about that all the time as we're building and developing and improving on our systems.
Thank you both for really bringing those points home. I think that's a great place to leave it. Jen, I will turn it back over to you for our last few minutes here. And thank you all so much. Thanks to each of our panelists for sharing your expertise and just being with us this afternoon. Really appreciate it.
Great. Thanks, Courtney. And a huge thanks to all of our panelists and the National Healthcare for the Homeless Council. This has just been a really great discussion. And to our audience, it was great to read your comments in the Q&A and see how you were connecting with the material and talking about your programs. We have the link in the chat, and Caitlin might be able to bring up the QR code for those who are technically savvy. For our evaluation, you'll be redirected afterwards to a certificate of participation with that. So again, as Alicia mentioned in the chat, sometimes the software website gets a little overwhelmed right after a webinar. So give it a few minutes after that. So with that, again, thank you to all of our presenters. We'd love to hear from the audience to see what you'd like to learn more about as we kind of plan our future programming. So with that, thank you all so much. Have a great day and take care.